At this meeting, we saw some very interesting neoadjuvant data with taselisib in the LORELEI trial, where there was higher clinical response. No PCR, good cell cycle suppression, but I think encouraging, and there'll be data with alpelisib at San Antonio in a neoadjuvant trial as well.
So Michael, do you want to talk about LORELEI a little bit for us as an investigator?
Yes. I think, and I may be biased because, it's also, we contributed a lot to this trial and we conducted it. And I think that's also significant information that needs to be made. This is an academic network trial together in a fair and transparent partnership with industry, which I believe is the role model to go for the future. So it's SALTI and the ABCSG and other groups under the big umbrella have conducted this. It's a randomized phase 2, 334 patients. And to me, as it was presented here, this is really very, very good news, because for the first time, a trial in this setting, in the neoadjuvant setting, could prove first that it can meet its primary endpoint closely at a significance level of 0.49, but still, so that we see improved response in basically luminal B disease when you add an alpha-specific PI3 kinase inhibitor to letrozole. And second, that the effect is even better in the molecularly defined mutant subpopulation, which I believe is a type of a proof of principle in a neoadjuvant setting we have been waiting for, at least I have been waiting for. I believe that's the significance. There's a lot of additional results from this trial coming up to be presented in San Antonio and probably later, including translational studies. But that primary endpoint result, to see that there is a 10% difference in the overall response rate for the combination therapy for the whole population and 17% in the mutation subcohort, I think is, let's say, guiding us towards the availability of a biomarker of another not too easy to use, probably not very cheap drug in the sequence, and together with the results from the metastatic trials that are, SOLAR and Sandpiper, as you have mentioned. I think in the next 6 to 12 months we are going to have a much better picture on, how to utilize PI3 kinase inhibition in our multi-pathway approach.
So, and again, LORELEI will be the final question that we'll have for this section. And I want to ask again, Michael, is there any role for these in the neoadjuvant setting? I mean, are the Gephardt group, are you doing trials with these agents? Targeted agents for luminal A, luminal B disease?
So number one, it was quite an interesting piece of proof that we go straight on from bench to bedside with this kind of trials. CDK4/6 inhibition. I can remember when the first data were presented, preclinical data and then the first clinical data, up until the approval now with multiple drugs, palbociclib, ribociclib, less than 10 years. Huge development, good for the patients. Same story, maybe with one of the alpha-specific PI3 kinase inhibitors, very nice story. And obviously, yes, we would like to see more data from the neoadjuvant setting as a proof of concept in the clinical setting, because the usual way was always second, third line metastatic patients treated and then move forward to adjuvant, and then we move to neoadjuvant. And now we see that we go the other way. And I'm very happy that this year's St. Gallen meeting in Vienna stated that neoadjuvant treatment is the better way to go, especially in high-risk breast cancer populations like HER2 positive, we'll come to that in a moment probably, and triple negative. Now what about lumil? PCR as an endpoint in luminal cancer was not the best way to look, and that is the reason why all those endocrine treatments, targeted treatments, didn't make it to the neoadjuvant clinical setting. As a proof of concept, I like very much what Michael Gnant just presented, that we look for the target, look how it works, and even find a subgroup of patients where it's working even better, PI3K mutations. And I think, and also with abemaciclib, Sarah Hurwitz's data from the neoadjuvant setting, very reassuring that it is the way to see how to develop a drug. Whether these drugs are going to make it in the clinical setting.
Right, that's the point. Will you ever use it clinically?
I would say again, and I come back to the statement from St. Gallen this year, I'm very happy to hear that we have it now in the clinical setting. High-risk breast cancer populations, yes, luminal B or luminal cancer at the moment, neoadjuvant treatment is not a clinical standard.
Okay. I just want to say the NEO-PAL trial was interesting here, comparing preoperative chemotherapy to letrozole palbociclib, and the objective response rates were the same. But in terms of the median with residual disease, PAF-CRs were very rare, but with regard to the median Ki-67 on the residual disease, it was like a median of 8% with chemotherapy and 3% with the palbociclib. So could that be a substitute for some patients?
Right, well, that's what I was thinking.
Question.
We are really struggling. You know, we screened with MammaPrint for I-SPY2, our neoadjuvant phase 2 randomized trial, and the people who are low risk by MammaPrint, you know, they often have tons of disease, and, you know, low risk, they have a high risk of recurrence and death. If we could give them targeted agents with endocrine therapy, I think it would be super.
Right, me too. That's what I'm thinking of. I mean, there must be a population out there with a big tumor that's luminal A, luminal B-ish, that maybe we ought to be treating with neoadjuvant endocrine therapy, with or without a targeted agent instead of chemo.
You know, but the problem with that, though, is that, you know, the bar is set by neoadjuvant chemo.
Right. No,
so
I agree.
both in terms of the surgical endpoint, breast conservation, in terms of, you know, PCR, which is, and I completely agree with Michael on this, you know, PCR is just a wrong endpoint. We keep picking it, not because scientifically, but the regulators want to see PCR, which I think for these agents is as rubbish as overall survival for luminal in the advanced setting. And in all these trials, for example, LORELEI, I mean, you have 16 weeks of treatment. The Panelists trial is going to have 24 weeks of treatments. When you talk to people who use neoadjuvant a lot traditionally, like Mike Dixon from Scotland, I mean, they have treatment durations in an elderly population, sometimes non-operable historically, 9 months, 12 months. Do we dare to do this in a situation where, you know, a quick anthracycline taxane combination could get rid of half of the tumor, even in luminal disease? Breast conserving surgery is done. So that's the problem for clinical standardization of this approach, also for surgeons, because we got used to these wonderful shrinkages, you know.
Although our surgeons, interestingly enough, at least the ones that I work with, are now really very cautious. They really are now doing more and more neoadjuvant endocrine therapy. They've decided someone comes in with a luminal A-ish like tumor, big, you know, doesn't want an operation immediately.
Ki-67 of 2%, they don't get big shrinks just with chemo.
They'll try endocrine therapy.
That's correct, but you have to see that, I mean, you know, in LORELEI, fortunately it was shown that with the 5 days on, 2 days off schedule, taselisib is quite manageable. So it's less than 10% of patients, you know, stopping the treatment, which is a little bit different from continuous in the metastatic setting. But still, these drugs are not easy. You have diarrhea, you have the rush, you have all of this. So I think it's going to, maybe if we can, and LORELEI is kind of showing us the way, I guess. If we can identify a mutant population where you can see we can have response probabilities which are similar to chemo in triple negative, for example, then I think for larger tumors, why not put the patient on 6 to 9 months of neoadjuvant endocrine plus targeted? So this is going to increase in clinical practice in the future, but it's going to be a slow development. That's what my prediction be.